Hi guys, we are moving on to chapter 18, which is the elbow and forearm complex. You'll be happy to know this lecture is going to be hopefully a little bit shorter than the shoulder lecture, so we'll just keep on moving on here. So, with the elbow and forearm, we are talking about a freely mobile but strong and stable elbow complex that's needed for upper normal extremity motion. The elbow is a pretty stable joint. Remember, it's going to flex and extend primarily. It does add pretty significantly to the mobility of the arm in that it's at the elbow that hinges to shorten the forearm, and we need to be able to flex the arm to do a lot of upper extremity functions. We also have the motions of supination and pronation that happen at the forearm, which is going to allow for rotation, which again has a lot of functional activities associated with that. Muscles at the elbow are going to provide some control and stability for the wrist and the hand to function. We know that the wrist flexors and extensors are going to attach at the elbow. And we need normal range of motion of at least 100 degrees. And we're talking an arc of motion of 100 degrees for normal ADLs. We specifically need that arc to be usually between 30 degrees and 130 degrees, which means we need to have a decent amount of elbow flexion to be able to perform most of our ADLs. If we're lacking some elbow extension, we can still probably do a lot of the things that we need to. So it is really important, and we'll talk about this sort of as we go through the lectures, that we get back as much elbow flexion as we can following elbow injuries because it is necessary for function. So some of the elbow joint characteristics, this should be review, mainly anatomy here. So the four major joints involved are going to be the humeral, ulnar, and the humeroradial, or the actual elbow joint. We have then the proximal radio-ulnar joint and then the distal radio-ulnar joint. Those are going to be working primarily in your supination and pronation. The humeral ulnar articulation is at the trochlea. There, it's a modified hinge joint. Again, the major motions are going to be flexion and extension, and where the humerus radiates. Where the humerus articulates with the radius, that's the capitulum. And again, it's these motions or these joints where we're getting the flexion and extension. So you can see in this picture here, here's the humerus where it articulates with the ulna, and the humerus where it articulates with the radial head there. So the joint capsule around the elbow is actually pretty lax. It's supported by two major ligaments, the elbow itself. It's going to be the medial collateral or the ulnar collateral or UCL ligament, which is going to provide stability on the medial side of the elbow, and the lateral collateral or radial collateral ligament on the radial side of the elbow. That's going to provide more lateral stability. So really, besides the joint capsule and those ligaments, it's mostly muscular support at the elbow. The way that the elbow joint is made as well, because of the deep socket in the ulna where the humerus comes down and fits into, that also lends to some of the stability of the elbow. So just the bony congruency there is going to make it a pretty stable joint as well. So again, this is just showing you on the radial side. Remember, we're going to have the lateral collateral ligament or the radial collateral ligament over here. And then on the ulnar side is going to be the UCL, the ulnar collateral ligament, or the medial collateral ligament. The proximal and distal radial ulnar joints are where we're going to get, again, pronation and supination. Those are pivot joints where they just kind of roll on each other. Proximally, the radial head is going to articulate within the radial notch on the ulna, stabilized by the annular ligament. Distally, the ulnar head articulates with the ulnar notch on the distal radius. So again, that's where we're getting our motions of supination and pronation, or rotation. So the major muscles involved for elbow motion, elbow flexors are going to be brachialis, biceps brachii, and brachioradialis. Your elbow extensors are going to be your triceps and anconeus. Your forearm supinators are going to be supinator, biceps, and brachioradialis, and your pronators are going to be pronator teres and pronator quadratus. Notice that I did not list your wrist flexors or extensors on here. We're going to talk about them more when we get down to the wrist and the hand. However, do keep in mind that they are attaching at the elbow, but they are not contributing really to any elbow motions. They do provide a little bit of stability at the elbow, though, however. I do want to talk a little bit about the nerve supply. And we are going to go into nerve glides once we get into lab to practice some of these. And so it's going to be important to know we can sometimes trace nerve issues back, knowing where the person is having symptoms into the upper extremity. So these are going to be the sensory distribution of the major upper extremity nerves, which are your radial, your ulnar, and your median nerve. So in this picture here, the ulnar nerve is represented by the green area. So it's on actually both sides of the hands, the palmar surface and the dorsal surface, the pinky finger and the half of the ring finger. So you can see that depicted on both sides here. The radial nerve in this picture is purple. It's going to do the dorsum of the hand, the dorsal side of the hand, up to about the proximal interphalangeal joint. It also does the outer aspect of the thumb. And then in this picture, the median nerve is represented by the light blue. So that's going to be the palmar aspect of the hand, the thumb on that side, as well as the first digits to the other half of the ring finger. So that's your median nerve. And where we hear about that very commonly, which we'll talk more about when we get to the wrist and hand, that's the one that's going to be trapped with carpal tunnel syndrome. All right, so to get into some pathologies of the elbow, first we'll talk about joint hypomobility or stiffness at the elbow joint. Some of the more common diagnoses where we might see that are rheumatoid arthritis is probably going to be one of the most common. Juvenile idiopathic arthritis, which is the newer name for it, used to be called JRA or juvenile rheumatoid arthritis. We can have arthritic changes at the elbow, although it's not nearly as common as some of the other joints that we'll see regular wear and tear type of osteoarthritis at. Trauma and dislocations and fractures are probably the more common types of trauma we see at the elbow. If your patient has any type of elbow trauma and they're immobilized, that can lead to adhesions of the joint capsule and contractures, again, especially after dislocations or fractures. And this is a little more common at the elbow than some of the other joints of the body as well, to notice some increased stiffness following immobilization. So with joint hypomobility, in the acute stage, you might see a little bit of swelling at the joint. You'll usually see muscle guarding of the surrounding musculature. There will be pain, which will often restrict motion, and they may often report pain at rest as well. As we move into more of the subacute and chronic stages, we'll start to see a capsular pattern as far as loss of motion goes. Remember, capsular patterns are going to be predictable directions in which motion is lost, especially if the capsule is involved. So remember, with RA, with OA, with some of these fractures and dislocations that we're going to talk about, those can happen within the capsule itself. So the capsular pattern for the elbow is that flexion is typically more limited than extension. And I mentioned earlier, we definitely need more elbow flexion to be functional than extension. So this can become a problem with our patients down the road. With these arthritic type changes, we might see some decreased joint play, and we will definitely have a firm end feel. So remember what the normal end feels are for elbow motion. Elbow extension is going to be, so normally elbow extension is going to be a bony end feel, which you may still get, but it may actually occur a little before. So if they're lacking extension, we expect a firm end feel with arthritic changes. Elbow flexion is normally a soft end feel. So again, with arthritic changes, that will typically transition into more of a firm end feel with loss of motion. There'll also be increased pain with pressure, like when they're carrying anything heavy or if they're weight bearing on their upper extremity, there'll be pain with those activities. So some common activity limitations when the elbow is involved. Turning doorknobs, turning keys in the car into the door, pain with pushing and pulling, like opening and closing doors, carrying objects, restricted hand to mouth, so things like eating and drinking, grooming, using the phone if you're talking on the phone, limited reaching abilities, pushing up to stand, and again, carrying anything as well. So in the maximum protection phase, when we have hypomobility, we want to protect the joint, educate the patient, try to keep motion to a minimum, avoid excessive fatigue with exercises, so they can do exercises a few times a day, but we want to limit the number of repetitions. Also, when we're doing exercises early on, we want to do more repetitions, less weight. You'll see as we go through with a lot of the elbow pathologies, restricting weight lifting is going to be sort of a common thread throughout. We want to reduce the effects of inflammation and prevent any adhesions or contractions from forming. So we can do passive range of motion or maybe even some active assisted range of motion within a pain-free range. So we do want to try to keep the elbow moving as much as we can. And we absolutely want to keep the adjacent joints moving as well. So we can add some grade 1 or 2 mobilizations at the elbow. We can do some pain-free isometrics and again some active assisted range of motion as long as the patient tolerates it. Movement of the wrist and the fingers and the shoulder, all the adjacent joints, again making sure that they don't get stiff because of whatever's going on at the elbow. And if edema would be present, there might be some slight swelling at the elbow itself, but if there is edema, oftentimes gravity will sort of draw that down to the hand. So if you do notice any edema in the hand developing with elbow issues, you can elevate and ice and do all the things that we've been taught in modalities to help to control that as well. In the controlled motion or the subacute phase or the moderate protection phase, if there is any continued hypomobility, so again loss of motion, try to do some joint mobilizations, some active range of motion, passive range of motion, whatever we can do to try to normalize range of motion again. We do want to be careful with stretching, especially if there has been a fracture at the elbow. There might be some specific contraindications. We want to make sure that everything heals properly. There is a chance for malunion. The other big thing at the elbow that we need to be careful of following dislocation or fractures is what's called heterotropic ossificans. There's a slide about this later, so we'll get there and I'll mention it again. But what that is this is one of those spots in the body where you can actually get an overgrowth of bone formation. And so if we aggressively stretch an elbow following a fracture, then there's an increased incidence that this could happen. So we do want to be cautious with our stretching. Again, sometimes we can do some joint mobs. The PT will do joint mobs or some mobilizations with movement to improve the joint tracking at the elbow as well. We can add some light resistance activities. Again, typically start with open chain activities. You can progress to closed chain as we get further along through this phase. We want to usually, again, start with endurance type activities, a low load for higher repetitions, and then we can progress to more strengthening activities as the patient tolerates. Definitely make sure that you're doing some wrist and hand exercises as well as some shoulder exercises when you're doing your strengthening exercises. And then as the patient is progressing and we get into the return to function phase, specificity training, again, so whatever the person needs to be getting back to, teach them some self-stretching so they can continue with that at home, and just continue to progress the exercises that they have been given up until this point. Also, again, think about what sort of functional demands that patient is going to have, pushing, pulling, lifting, carrying, any type of repetitive work if they need to do that. We want to try to simulate that in the clinic and make sure that they're able to do those activities before they go back to work or to home. Okay, so now we're going to get into some surgical procedures for the elbow and then how we care for those. So one surgical condition that we might see is for displaced radial head fractures. Radial head fractures are the most common fracture to occur in adults at the elbow. So one thing that we can do, or the physicians can do, is the ORIF, which remember is the open reduction and internal fixation. That's usually for your younger, more active adult. So they'll go in and they will put usually like a plate, screws, pins, rod, whatever they need to in order to repair the radial head. They may have to do a radial head excision where they actually remove part of the radial head. If the radial head is crushed and it's not going to heal back together, then they may just remove the pieces of that bone. And then they may do a radial head arthroplasty where they replace it with a prosthetic radial head. So they might need to do an open excision of those bone fragments if there's a spiral or a comminuted fracture of the humerus. So if it's a fracture that's just in many, many pieces, they will oftentimes have to remove the radial head and again, may or may not use an implant. If they do not, they usually just do not use an implant if it's a low demand patient. If the person is going to be more functional, then they usually will put a replacement radial head in place. This is how the radial head gets shattered in adults. It's typically from that fall on the outstretched hand, the foosh, right? You put your hand out to protect, the humeral, or the end of the humerus dislocates out of the olecranon and comes down and just crushes on top of the radial head. So again, that fall on the outstretched hand, or what we sometimes see too is the Colles fracture, which is going to be the wrist fracture. So that's down at the distal radius. That's that dinner fork deformity where you'll see the wrist sort of pop up. We'll talk about that when we get into the wrist lecture. But again, this radial head fracture, pretty common in adults from falling on their hand. So indications and goals for surgery at the elbow are primarily going to be pain relief and restoration of bony alignment, to increase the strength and range of motion and restore normal function at the elbow. Procedures that are done to relieve pain and improve stability tend to be more successful than procedures done solely to increase range of motion. They have found that doing a surgery just to try to improve range of motion, if the person does not have pain or significant functional deficits, are not usually as successful. So just loss of range of motion at the elbow is not necessarily an indication for a surgical intervention. Again, the main reason for that is due to heterotropic bone formation. It's a complication following elbow fractures, dislocations, and elbow joint surgeries, which can lead to stiffness and unsuccessful increases in range of motion. So sometimes the patient can actually end up worse off following an elbow procedure than they were going in. So again, just having a loss of range of motion is not typically a reason to do a surgery. So a radial head arthroplasty, again, if there is a severely comminuted fracture, which again means it's in a lot of pieces and they're not able to put it back together, if the patient has had chronic synovitis and deterioration of the joint surfaces due to a disease process, aka rheumatoid arthritis, that's where we tend to see that happen a lot. It sort of erodes the synovial area there. Subluxation of the radial head, so it's dislocating typically out of the annular ligament and then sort of out of the notch there, and then significant loss of upper extremity function. They will typically not do a radial head arthroplasty in a growing child, or if the elbow is unstable, there's a displaced fracture, or where internal fixation is not achievable. Okay, so excision of the radial head and radial head replacement, they will typically use a lateral triceps sparing approach. So what that means is they'll go in from the lateral side of the elbow and the triceps will remain attached or intact. The radial head is then removed at the level of the annular ligament and then is replaced with a prosthetic implant. If there's any instability present, they will repair the ligamentous structures as well to make sure that the elbow will be good and stable as it heals. So following radial head removal, the elbow is typically immobilized in a splint at 90 degrees in mid-position of the forearm, so neutral, supination and pronation for 1 to 3 days. If the ligaments were reconstructed, they will be immobilized for even longer. The maximum protection phase is going to last usually about 2 to 3 weeks, so control edema and pain, maintain mobility of the unaffected joints, so the wrist, the fingers, the shoulder. You can do some passive range of motion at the elbow in a pain-free available range and begin some submaximal multiple angle isometric exercises. The moderate protection phase is going to begin about 2 to 3 weeks post-op, and then it's going to last an additional 8 weeks. The goal here is to improve range of motion, so we'll do some low-intensity stretching. Again, remember, we're not going to really aggressively stretch these patients. We can do some possible splinting with them, or dynamic or static splinting, and grade 1 and 2 joint mobilizations will help to decrease pain. We want to improve strength and endurance. Again, the low load, high reps to focus more on endurance than strengthening. As we move into the minimum protection phase, this can range anywhere from 2 to 6 months. Again, maximize the amount of range of motion that we're able to get back. We can move into grades 3 and 4 for joint mobilizations. begin to restore or continue to restore strength and endurance, so we can move into free weights, resistance bands, weight machines, again, to the patient's tolerance, and then try to get them back into recreational and work activities. So figure out, again, what type of activities do they need to do as part of their daily routine, and make sure they're safe in doing those. The long-term goal with all of this surgery, again, the radial head replacement, is, again, to make sure that we have a stable elbow with pain-free range of motion within the functional limits. So again, making sure we have that functional flexion back. We do want to avoid using that upper extremity for moving or holding heavy objects. So they probably want to avoid really heavy lifting with that side. We do want to make sure that we're avoiding varus and valgus stretching and while we're in terminal extension or terminal flexion. Not likely to do them in flexion as much, but in terminal extension, especially if the radial head was not replaced. So if they did not put a prosthetic radial head in, or if the question of the stability of the ligaments is there, then we want to be very careful with varus and valgus stretching at that elbow. Okay, total elbow arthroplasties or total elbow replacements. I can personally say I've never seen one of these. These are not very common joints to have replaced. It's probably getting a little more common at this point, but we'll talk about why these aren't the most popular joint replacements here in just a minute. The indications for doing a total elbow arthroplasty are going to be severe joint pain and articular destruction with loss of range of motion. For underlying conditions with like rheumatoid arthritis, again, that's going to be the most common condition where we'll see a total elbow replacement performed. Juvenile rheumatoid arthritis or osteoarthritis, or if there's gross stability at the elbow because of deterioration of any of the components of the elbow. They may also elect to do an elbow replacement if there's a comminuted fracture or a non-union fracture of the distal humerus. If there's been a failed resection of the radial head, so they've already tried to replace the radial head and it is not working, which does happen occasionally, or significant limitation of motion at the elbows. So they do typically try to reserve this for people who are at least 60 to 65 years. This is not one that can easily be revised, so they usually want to try to keep it to just one elbow replacement without revision. They are starting to consider it a little bit for more younger patients, but they are going to have lifetime lifting restrictions. So that's, again, one of the reasons why this is maybe not super popular. It is preferred over open reduction and internal fixation for severely comminuted intra-articular distal humeral fractures in the elderly. So instead of trying to put them back together, they may just go in and go ahead and do an elbow replacement. So probably the biggest reason that elbow replacements are not that common is because complications are more prevalent following this type of surgery than any other joint replacement. And there's 3 major complications that we need to watch for following a total elbow replacement. And those are joint stability, triceps insufficiency, and the implant loosening. So to do an elbow replacement surgery, they will do a longitudinal incision on the posterior aspect of the elbow. They may be able to spare the triceps, but oftentimes they have to actually detach the triceps, perform the elbow replacement, and then reattach the tricep. The ulnar nerve is going to be moved out of the way and the ligaments are released. The distal humerus and proximal ulna are resected or removed, possibly the head of the radius too, but it at least has to be the humerus and the ulna. Their canals are prepared and the components are put into place. They're cemented in place, and then the ligaments are repaired. Triceps is reattached if it was detached, and the incision is closed. I have pictures of constrained versus unconstrained. This is the unconstrained elbow replacement. So you can see this is where they prepared the canal. So they actually drill down into there to put the replacement in. So there's a part or a piece that goes into the distal humerus, and then a part, this is actually going into the radius here. So they replaced the radial head. So you can see it done there. You can also see it, this is more of a hemi-arthroplasty. You can see it done through the whole joint as well. So over on this picture, this is the unconstrained version. This is the constrained. And what constrained means is that it's linked. See how it's hinged here? So that's going to provide a little bit more stability at the elbow. So post-op, the patient may be immobilized in a splint for up to 6 weeks, but at least at night for 6 weeks. They might be wearing it all the time for at least a week, maybe longer, depending on what all is going on. It depends on the structures involved, how much was repaired, and they will most likely be in more of an extended position to protect the healing tricep. The patient can usually take their splint off for exercises and self-care as long as they keep in a pain-free range at the elbow and prevent any adhesions from forming. So we can start doing some passive motion with them. They can even do some self-passive range of motion at home. As soon as we can get rid of the immobilizer, we want to, right? As soon as they don't need to wear the sling or the splint anymore, again, because of some of the complications that can occur following elbow procedures, we want to try to get them moving as soon as we possibly can. So exercises in the maximum protection phase, we want to minimize any edema in the hand. We want to maintain mobility at the wrist and the shoulder. So making sure that we're taking the sling off or taking them out of the immobilizer for periods of time and doing exercises in those areas. This is where it would also be really good to give them like a ball to squeeze that works the fingers, works the wrist, helps increase circulation, and they can do that with their immobilizer on as well. We want to try to get back motion at the elbow and the forearm, so we can start with some active assisted and progress to active range of motion in a pain-free range. Again, with the forearm in a neutral mid position. We want to limit flexion to no more than 90 to 100 degrees for the first 3 to 4 weeks. And again, this is to protect that triceps that's healing. And we can perform flexion and extension in seated or standing, typically not in supine. So we do want to support the elbow, and we may even begin with some anti-gravity type flexion and extension motions. We do want to minimize atrophy of the remaining upper extremity musculature, so we can do isometrics for the shoulder, which we talked about in the previous chapter. You can do things for the wrist and hand. Like I said, ball squeezes are really good for this time frame. Again, we want to emphasize end range extension before we really start pushing into flexion. And again, that's to protect the posterior capsule and the triceps so that they are allowed to heal. We also want to postpone supination past neutral if the elbow stability is in any type of question. So we can work on pronation. We just want to avoid end range supination for a period of time. So moving into the moderate protection phase, this usually begins around 4 to 6 weeks, again, depending on how many structures were involved in the elbow, and it usually lasts until about 12 weeks. Lifting restrictions may remain forever, potentially. This is one where the person is usually going to have permanent lifting restrictions with that upper extremity. I've looked into some different protocols, and the most I've seen patients be allowed to lift lifetime is 10 to 15 pounds. So I put a permanent lifting restriction of 15 pounds here. That was the highest I saw. I did see some where they were more limited to 5 to 10 pounds forever. So again, this is a reason that we don't see tons and tons of elbow replacements. So again, in this moderate protection phase, we really want to focus on range of motion, making sure we're getting that back. So some low intensity manual stretching, self-stretching. We might use some splinting again here. Joint mobs are typically contraindicated. Again, we have prosthetic components in there. And again, we're going to emphasize end range extension before we start to really push into flexion. We're going to postpone resisted elbow extension for 6 weeks or maybe even as long as 12 weeks, depending on the physician's orders. So again, that's resisted triceps exercises because, again, the tricep may have been reattached, and so we need to allow that time to heal. When you're strengthening the shoulder, try to put the resistance above the elbow to reduce the stresses on the elbow joint. So that might mean putting like an ankle cuff weight around like the bicep tricep area, or attaching your TheraBand up there, tying it around their arm up there, not like a tourniquet, but just putting your resistance up there so they're not holding it in their hand and then there's a lot of force put on the elbow. We may have to tell the patient that they can't use their upper extremity, or at least that one upper extremity, to push up from a chair, and they are typically not supposed to use assistive devices in that hand or carry heavy objects for about at least the first 6 weeks. Again, repetitive lifting, typically like a pound for the first 3 months, 2 to 5 pounds for the first 6 months. I have seen some protocols where 5 pounds is it forever, and then no more than 5 pounds repeatedly or 15 pounds for a single lift as usually permanent lifting restrictions. High load resistive exercises are typically not appropriate following a total elbow replacement, so they will never be lifting heavy weights with that arm again. Myositis ossificans or heterotropic ossificans or ectopic bone formation, they all mean the same thing. What it means is formation of bone in atypical locations, so the musculotendinous unit, the capsule, or ligamentous structures. At the elbow, the most common area for this to occur is the brachialis muscle or within the joint capsule itself after a trauma. And that can be a comminuted fracture of the radial head, any fracture of the elbow, especially if it occurs intracapsularly, a tear of the brachialis, or an elbow dislocation. So actually the elbow and the thigh are going to be the two most common spots in the body to develop heterotropic or myositis ossificans. When this occurs, bone is going to actually grow 3 times faster than normal, and it's jagged, and so it's very painful for the person. It's also a little bit more common in patients who've had traumatic brain injuries or spinal cord injuries or even burns. And it can develop after aggressive stretching of the elbow flexors following trauma or following an immobilization. So that is one of the reasons that we don't aggressively stretch someone's elbow following trauma. It can be confused with traumatic arthritis. Myositis ossificans is going to demonstrate itself by having passive extension being more limited than flexion. So getting terminal extension is a little bit more difficult than flexion. There will be pain with flexion though as well, because you have this bony growth in brachialis. And so when you flex, that's going to start to get pinched in there. And so that can be painful. Resisted elbow flexion is going to cause pain in the brachialis muscle. And the bone is actually laid down in individual muscle fibers and around the joint, so it will feel firm to touch. You can palpate these myositis ossificans when they form. So to manage this, again, massage, passive stretching, resistive exercises are going to be contraindicated following trauma. The elbow should be kept at rest and splinted and should only be removed for pain-free range of motion. So you can do some range as long as it doesn't hurt. Typically, what we really want to do is just rest. Let these patients rest for a period of time because bones should be reabsorbed within 2 to 4 weeks. Rarely will they go in and surgically remove this bone. It would honestly be too hard to actually pick it out of all those muscle fibers. So they usually just have to wait for it to start to be resorbed. Like I said, my youngest brother has one of these in his quad muscle. It has shrunken over time. I mean, he got it when he was a kid, but it is still there. It doesn't cause him any pain. It's not limiting his function, but he does have sort of a permanent bump in his quad. Okay, so let's talk about some overuse syndromes. We have mentioned before many times lateral and medial epicondylitis. So lateral epicondylitis or tennis elbow is pain in the common extensor tendon. So it's located on the lateral side of the elbow, usually with gripping type activities. So things like gardening, backhanding in tennis, that's where it got its name, or any activity that requires repetitive extension of the wrist can lead to inflammation of the common extensor tendon. I've seen it also in like construction workers who do a lot of hammering. They can flare up the lateral epicondyle with that. Medial epicondylitis or golfer's elbow is in the common flexor or the pronator tendon coming off of the medial epicondyle. So this can be associated with the golf swing, throwing, or any activity that requires wrist flexion. And you may also see some ulnar neuropathy with this one as well. So what we see this is usually after repetitive use or eccentric strain of these muscles. It's micro damage and partial tears of the muscle tendons or the musculotendinous unit where the strain again exceeds the strength of the tissue. So you'll typically see a gradual increase in pain. This is not something that usually happens quickly all of a sudden. It's usually more of a gradual onset. There's pain when the muscle either contracts or when it's stretched. So both activities will actually cause pain in the muscle. The person will have decreased muscular strength and endurance because it hurts to use that muscle. They typically exhibit decreased grip strength that is limited by pain. So this is someone who will usually measure their grip strength side to side to compare. And they will typically have tenderness to palpation along the site of the inflammation. This is usually a non-operative type treatment. So in the maximum protection phase, we are going to want to manage their symptoms. So this is where we can jump in with use of modalities. Ice, massage, ionto can work well here. It's usually pretty local symptoms. So control the pain, control edema, maybe splints. I don't see those used too commonly. Trying to stop the aggravating activity, which may be easier said than done, especially if this is part of the person's job to do whatever activity it is that flared up their symptoms. Ice modalities, like I said, ionto can work well here. Immobilization, again, resting, splinting, maybe. Patient education to try to avoid those activities. Maintaining soft tissue integrity, so we might be able to do some isometrics in a pain-free range, cross-friction massage. And then if there is any nerve involvement, we can do some neuromobilization techniques or nerve glides, which we will get into when we get into the lab. And I believe I showed you some videos on some of these nerve glides as well. So again, if there is any nerve entrapment, we can work on those. In the return to function phase, we can do stretching to make sure we have full range of motion at the elbow and wrist, although we don't typically see a lot of motion restrictions. It's more pain and inflammation. We can continue with cross-friction massage. We can actually teach the patient how to do that on their own. We can do some joint mobs to improve joint tracking, improve muscle performance and function, aka some strengthening, again within a pain-free range. We may end up prescribing something like an elbow sleeve or a strap to use just to take the load off. What those do is they typically just shift the load elsewhere along the muscle. We can do some resistance exercises, again, usually start more on the endurance side of things, higher reps with lower weights, and then progress to strengthening, and then eventually plyometrics like throwing, and then progress to functional training and conditioning. They may need activity modification. Again, they may need some splinting, straps, elbow sleeves. The big thing is that we were trying not to exacerbate their symptoms during rehab, and this is one of the more difficult parts about treating someone with epicondylitis. It's often hard to find that right combination of exercises where we're doing enough to try to maintain range of motion and strength, but we're not further irritating their symptoms. So take it slow with these patients, control what you can through use of modalities and things like that, and then just keep everything at their tolerance. For operations, for overuse syndromes, there's not a lot. Lateral epicondylitis would have to be pretty severe for them to do surgery, but they can go in and they can do a debridement. Typically, it's arthroscopically done, or they could do a percutaneous extensor tenotomy, which you can watch that video if you want to. That is basically just a tendon release to try to to reduce some of the pain there. Where we do see a fairly common surgical procedure at the elbow is the ulnar collateral ligament injury. It's become more and more popular due to injury among pitchers, or I guess we hear about it more often. It can look like medial epicondylitis, so we have to be able to tell the difference. One thing is palpation, although the area is pretty much the same. Where you'll find the ulnar collateral ligament is right off of the medial epicondyle. There are a couple of special tests that we can do to try to differentiate between a UCL injury, like doing a varus and valgus stress testing to determine whether or not that ligament is intact. If the ligament is injured, you'll have a positive test. If it is not, if it's more medial epicondylitis, the ligament should appear fine. Also knowing the mechanism of injury. What did the person do? Is this more of an overuse type thing? Was there a traumatic event? Did they feel a pop or have like some sort of event where they can pinpoint where it happened? And there may also be some ulnar nerve symptoms with this as well. So non-operatively, we want to try to alleviate the symptoms, look at all the contributing factors, like if it's a pitcher, how can we work with them to try to work on their throw so that they can preserve the UCL as long as possible. If the ligament is completely torn, it is typically not going to heal itself, so that's when they will have to have surgery, which you've heard of as Tommy John surgery. There will be protocols that come along with this, so just make sure that you are following that. Typically, as with a lot of these types of ligamentous injuries, if an athlete sustains this type of injury and has the surgery, it will usually be about a year before they can return fully to their sport. Cubital tunnel syndrome is another, it's a nerve entrapment that you might see at the elbow. It's when the ulnar nerve, the ulnar nerve gets impinged in the elbow between the medial epicondyle and the olecranon, or like when you hit your funny bone and you feel that stinger kind of go down your arm, same thing. This is just a little bit more permanent. If it continues over time, this nerve entrapment, we can actually see what's developing as a claw hand, where you see a curling of the 4th and 5th digits on the hand, and you might start to see some atrophy of the hypothenar eminence as well. So for cubital tunnel syndrome, again, we can try to manage this non-operatively. We can do some nerve glides. We can use modalities to try to relieve their symptoms. We can work on range of motion, strengthening. If all of these things don't work, then they may go in and do a surgery where they can actually sort of debride the area, remove some of the buildup in that area where the nerve is being pinched. They may actually end up sort of transposing or moving the nerve as well to a place where it will not be as likely to be impinged. So again, conservative treatments, protecting the elbow. We can put a protective splint on, especially while the person is sleeping. We can use an elbow pad to avoid any direct pressure or any further impingement on that nerve, and avoiding repetitive motions will help to take some of the pressure off that nerve as well. If surgery is indicated, which again should be sort of a last-ditch effort, they will decompress the nerve, or they, like I said, they may move it, transpose it. So they'll usually move it a little bit more anteriorly just to get the pressure off of that nerve. All right, so those are the major conditions of the elbow. The big thing I want you to take away with the elbow is that most of the elbow protocols that you're going to see, or elbow rehabs, are going to be relatively lengthy. So while we don't see a ton of elbow injuries, we do need to take special caution when we're treating patients because of some of the potential complications that we might see. All right, we'll be following up with some case studies for the elbow as well.